Virtual Education Symposium. My name is Bob Duffy. I'm one of the PFAC co-chairs along with Elise Elkonen Goldberg, and we're really happy you could join us today. As you probably just heard, this presentation will be recorded and made available on our PFAC website for anybody who was unable to dial in today. We've got three wonderful speakers lined up for you with information that we hope you find informative and useful as we all navigate our individual journeys through this unique transplant experience. At the end of the presentation, Elise will moderate an open Q&A session. If you have any questions during the presentation, please write them in the Zoom chat and we will pass them along to the speakers at the end of their talk. So, moving ahead, our first speaker is someone I'm sure you're all very familiar with, Dr. Gundeep Dhillon, Medical Director of the Transplant Program and Associate Professor of Pulmonary and Critical Care Medicine at Stanford. Dr. Dhillon is here to give us a welcome and share the latest updates on the clinic and any news. And with that, I'd like to welcome Dr. Dhillon.
Thank you, Bob. I've been fortunate, good afternoon. And, I've been fortunate to know almost everybody who's on this call. Again, I'm Gundeep Dhillon. I'm one of the lung transplant pulmonologists here at Stanford, and I've been here almost 20 years now. It's really amazing how quickly time flies. So again, thank you for being here and welcome to this wonderful, webinar, which Bob and Elise put a lot of efforts into putting it together. And I also want to thank Joanna and Feifei for taking time to be part of this webinar. So from my perspective, I just want to give a quick update on the program. I'm sure most of these things you probably already know, but 2024 was another, we continue to grow as a program. I think last night we did our 78th transplant for the year. Last year was our biggest year by volume. We had done 84 transplants. I think we are going to get close. I think we are doing our 79 tomorrow. So I'm hopeful that we'll get to the same number, around 84, 85 transplants, which is, as lung transplant programs go, is a big number. And, we are probably one of the top 10 programs in the country by volume and hopefully by quality. We work very hard on, providing good care. So that's as far as where we are as a program, volume-wise. We continue to be we are the largest program as far as when it comes to heart-lung transplants. We end up doing plurality of heart-lung transplants in the U.S. every year. And we also have really made multi-organ transplants, whether it's lung kidney or lung liver as one of our focus areas. And, we have had great partnership with our abdominal transplant folks to kind of develop those programs. So that is going very well. One of the other things we have been really working on, and a subject which is very near and dear to me, is really continue to improve access to procedures like organ transplantation. There is no doubt that we have areas which are well served, and we happen to be in one of those areas. Bay Area is very well served when it comes to access to therapies like organ transplantation. But within 150 miles of us, there are literally medical deserts, where there are populations which are very underserved when it comes to access to these kind of therapies. So we really have made a focus of our program about, rather than expecting patients to come to us to improve access, to actually go where we think there is need. And this has been an ongoing effort, but it has really kind of accelerated over last year or two. We all, for last 5-6 years, we have had a very successful program in Las Vegas. But in last year, we have just started another outreach clinic in San Luis Obispo area. and because that's one area which, again, surprisingly is underserved when you look at the amount of people who live there and amount of lung diseases out there and actual transplants that happen. We are developing partnerships with UC Davis and Fresno and some local physicians in Fresno area, again, to improve access. When I say improve access, where we do most of our work in those communities rather than putting the burden on our patients to come to Stanford, where we are going to go out there and try to get most of the pre-transplant and some of the post-transplant work done in their own communities rather than, expecting people to drive hours and hours to come to Stanford for a 30-minute visit and things like that. So that's been one of our areas of focus. And obviously, these efforts take a lot of time and resources. And I want to thank Stanford Healthcare. They have been a great partner with us on this. And I can honestly say, I talk to a lot of other transplant physicians and surgeons around the country. And I can honestly say that Stanford has been one of the better partners. We always hear these horror stories about the healthcare systems nickel and diming their programs when it comes to giving them enough resources and staff. We actually don't have that problem at Stanford, which I'm very thankful for. We have been able to continue to grow when it comes to our pre-coordinators, our post-coordinators, as well as our APPs. We have also hired 2 new physicians, which some of you might know. Both of them were our trainees. Dr. Amba, Samriddhi Amba, she was a transplant fellow, I want to say 3 or 4 years ago, and we have been able to recruit her back. And then Dr. Ian Britton, he was also a fellow at the same time as Dr. Amba, and he had moved, but he lives in San Luis Obispo, so he's going to run our clinic down there. So, so we are having a program, to continue to support the program growth and do it well. We are continuing to able to recruit and retain our people, which we are very proud of. We have been very fortunate when it comes to not only recruiting, but also retention. So I think, which is again, very important to me personally, but I do think it's very good for the programs to have that stability. What else I could tell you? As far as when it comes to taking care of people, who most of people on this call are, who have already undergone transplant and post-care, like I said, we are really making efforts to improve our clinics. We are working with HHC. There might be some changes in our clinic space, just because, now we are starting to get to where actual physical space is becoming a limitation for us as far as growth and seeing people efficiently. So we are working on that. So that's something that hopefully will happen in 2025. We might move into a new space. When I say new space, it's still going to be at the main campus. We are not talking like at Redwood City or off campus, but somewhere on the main campus. I think hopefully we'll have that. And the other thing which we have been very excited about, again, to simplify or minimize the burden of all these clinic visits and things like that. The whole transplant service line at Stanford has we have kind of working with, believe it or not, Best Buy to develop a remote patient monitoring, which is, and I think lung program is going to be the first program. And what that would look like for us is most of our transplant recipients who are 6 months or more after their transplant, and when they have moved back to their own communities and living home, just to minimize their clinic visits, they are going to have a spirometer at home. They'll have all these machines at home where we are getting data regularly so that we feel comfortable seeing them less often in the clinic or requiring them to come to the clinics less often. Again, but at the same time, do it safely, because we will have all this data incoming. So anytime there is any reason to see somebody early and we can respond quicker, we see a dip in somebody's lung function or their vitals and all that, where we say, hey, why don't you come? But if somebody's very stable, we say, you don't need to come every 3 months. We can go to every 6 months, since we are getting the data very frequently, whether it's daily or I'm assuming for people who are otherwise doing well, it'll be more like twice a week or weekly that we would get that kind of data. So we are going to be the pilot program for that, the lung transplant program, and I'm very excited about that. So that's all I have to share, and I'm happy to stop here and take any questions. Thank you.
Okay, we thank you for all those updates. The virtual one is exceptionally exciting. We don't have any questions. And so I know you need to leave and go back to the ICU and do your job. You're wonderful. And you do it very well. So I'm going to give it to Bob.
Thank you for having me.
Thank you so much for joining us today.
Yeah, and thank you, Dr. Dhillon. And now I've got another reason to go to Best Buy. So I was very thrilled to hear that. I'm not just going to be looking at big screen TVs. So that was a great tidbit. Very, very happy to hear that. Okay, our next speaker is Feifei Yang, a nurse practitioner with the Transplant Clinic. I'm sure many of you are familiar with her. Feifei will be sharing information about a topic that I'm sure we're all interested in, which is medical interventions for immunocompromised patients with chronic or acute rejection. So welcome, Feifei.
Thank you, guys. Good afternoon. I'm Feifei. I'm a nurse practitioner from the lung transplant team. I work sometimes in the inpatient, sometimes clinic. Probably I see some of you already in clinic or in the hospital. I'm so glad to have this opportunity to share this information. So my coworker Ashley is supposed to be with me, and I think some technical issue there. So I will start for now, and we will wait to see. We'll share my screen. Share. Okay. Can you see my screen?
Yep, we have it.
Okay, perfect. Okay. So we are going to go over the medical interventions for the immune-compromised patients. Here's our lung transplant patients with chronic or acute rejections. So here, the rejections, basically, there are acute cellular rejections, antibody-mediated rejections, and the chronic rejections. I will go over the acute cellular rejection and chronic rejection. Ashley is going to cover the antibody-mediated rejection. Yeah, and I will leave that part for her. Later, she will, once she get in. If the technical issue is not going to resolve, I will cover that part as well. So, so we will focus on the how to diagnose this, what is the criteria, and once it's diagnosed, how we treat these rejections. Acute cellular rejections is most common within the first year after the transplant. So normally the signs and the symptoms, the PFT dropped, the spirometry test. Every time in the clinic visit, we have the PFT test. That's very important. We follow up that, we just monitor that test and follow the trend. That's very important. And some patients have dyspnea, hypoxia, or fever, or shortness of breath with exertion. Or some patients just told us that they feel fatigue and easy to get tired, but no respiratory issue. And the chest X-ray sometimes it's normal. We cannot tell from the image. Sometimes there's some infusion or infiltration on the image. But the most important or the reliable diagnosis tool is the transbronchial biopsy. So we will do the bronchoscopy, do the biopsy, and we will take a piece or couple pieces of tissues from the lungs, and then send to the lab, do the pathology test, and that will give us a a definitive answer. But sometimes if the tissue is not adequate, so will not have when they will tell us it's X, means they cannot tell us it's rejection or not. So and in that case, if the patient's lung function declined and there's no signs of symptoms or infection, we still will treat as presumed rejection. So since this happened very common in the first year, so in the first year, we have a very frequent routinely surveillance bronchoscopy for our patients happening in the post 6 weeks, 3 months, 6 months, and 1 year. So well, just this is surveillance. Just even though you feel okay, you are great, we still need this bronch to check the lung any acute rejection earlier. Because I said earlier, like sometimes there's no symptoms, you cannot feel anything. The earlier we catch it, we can treat it earlier. The result will be better. Yeah, so for once it's get diagnosed, the treatment for the acute cellular rejection is here in our program, we give the high dose steroids, sodium iodrome here in our program. It's a weight-based. Sometimes we give 500, sometimes 700, depends on how the weight of the patients. It's a 3 days. It's once a day for 3 days as IV infusion. Since it's the steroids, so the sugar can be very challenging after this high dose steroids. So normally we will involve the endocrinology team to help us manage the sugar. If the sugar within 3 days controlled pretty well, on day 3, after the 3rd infusion, patient can go home. Otherwise, they probably need to stay to 1 more day to make sure the sugar is under control. So after the treatment, we will reevaluate patients' immune suppressant levels. We need to make sure the drug levels is in range. Like either the Prograf, everolimus, cyclosporin, either 1 or 2 of the medications is normally the patient take. This is one of the most important medications for our post-lung transplant patient. So we need to make sure the drug level is appropriate. That's why our nurse call need to always call patient to do the labs, and we review the labs. We notify patients whether the drug level is good or not. We need to adjust the medications. If it's too high, it will damage the kidney. It's very toxic to the kidney. If it's too low, we will instruct patient to increase it or decrease it based on the levels. This is very important. So also patients should be very compliant with the medications. If you miss doses, all the things by any accident or don't take enough medication when you travel, you need to tell us right away. Or like nauseous, vomiting, cannot keep medications down, or diarrhea, all these, the GI issues should let us know right away. And also after we check the medications and make sure all this good, we will evaluate any reflux disease, like the acid reflux. This is a risk factor as well, because the acid reflux, if the inside of goes to the stomach, it will go the wrong path to the lungs. It will makes the cause the lung have the chronic inflammation, which is it's the risk factor for the chronic acute and chronic rejection. Later we will talk about that. So that's why after the lung transplantation, after lung transplant surgery, we always refer our patient to the GI doctor. That's the routine, yeah, for there's a protocol for every patient. we'll do a pH manometry study. This is the test will tell us whether the patient have reflux or not. If that's the case, so we will refer to the GI doctor. Well, yeah, we'll treat it to decrease to just get rid of these risk factors. Okay, so next is the antibody-mediated rejection. So let me check Ashley.
Hi, I'm here.
Hi, Ashley. Okay, perfect.
Hi. My name's Ashley Batchelder. I'm one of the nurse practitioners with the transplant team at Stanford. So I'm going to discuss antibody-mediated rejection, which is one of the complications following lung transplant or any transplant. So antibodies are proteins that our bodies make to protect against foreign invaders. And in this AMR, what happens is your immune system mistakenly identifies the transplanted organ as foreign or harmful. And as a result, you produce antibodies that thereby attack the transplanted organ. And that's essentially what happens with AMR. AMR can cause inflammatory changes in the lungs, and that can essentially reduce your lung function. As most of you know, we monitor your lung function regularly as an inpatient and outpatient during your clinic visits. This is one of the best ways for us to track your overall recovery after transplant and monitor for complications. So over a period of time, if we start to notice that your pulmonary function testing is declining, this might, raise suspicion that there might be a complication happening. Now, after transplant, there are a lot of complications, including infections, bacterial, viral, volume overload, cardiac issues. And once we are able to definitively rule out other etiologies for the cause of the decline in your lung function, we may do a blood test called DSAs. What DSA blood test does, it stands for donor specific antigen, and it is looking to see if there are high detected levels against the organ donor's HLA, which is, and so if those are detected at a high enough level, then it's reasonable for us to assume that there may be an AMR component causing the reduction in your lung function. This can also be done through bronchoscopy, and where you'll have the bronchoscopy, they will take a biopsy, and then on histology, you'll see C4D staining, which can suggest AMR is happening. So once we have have a high degree of suspicion that you are experiencing AMR, we will call and ask you to come into the hospital for treatment. Now, it's important to note that there is no universal consensus on treatment for AMR. I believe it varies by program. At Stanford, our treatment protocol is as follows. So we will ask you to come in. You will have a central line placed, which allows for the drugs that we're going to give you to be infused safely. You're going to get 3 days of high-dose steroids. During the first 3 days, you will also be started on something called plasmapheresis. You'll be doing the high-dose steroid for 3 consecutive days and started on plasmapheresis. This is something that will happen over the course of 10 days for 5 sessions. So we usually do every other day, which helps patients sort of recover after these sessions. Sometimes you might feel lethargic or, you know, just really tired. And so doing it every other day just kind of helps people tolerate the procedure. So once you are through that phase of treatment, we will give you a drug called IVIG. IVIG is given in 2 infusion cycles in 2 consecutive days. And that just helps further sort of suppress your immune system. And then following that, you will get a drug called rituximab. Rituximab is given in 1 infusion, and then afterwards you are discharged home and you'll get the 2nd infusion in about a week's time. So that is a very involved, AMR is a very involved you know, treatment plan, which spans about 14 to 16 days, depending on patient-specific responses and things of that nature. So it kind of varies patient to patient, but we like to tell people that you should expect to be in the hospital for about 2 weeks. Once you're discharged, after completing those initial stages of therapy, you will continue receiving IVIG on a monthly basis. So similar to what you received in the initial phase, you're going to get 2 infusions in 2 consecutive days. Prior to getting that infusion on a monthly basis, we're going to check your DSA levels to monitor for response to this therapy. So by doing that, we can see is this particular patient responding to this treatment course. So our objectives for treating AMR, hopefully everyone has some response to AMR therapy, but it does vary. So there's 4 different responses. The first is a complete response, which is your graft function, meaning your pulmonary function testing, returns to your baseline level, which is the level that you sort of achieved after getting the transplant. So it's kind of like your high level where before you started to decline. And then we will also see serologic evidence of the DSA titers being lower and lower and hopefully completely removed. The next outcome is a partial response where your pulmonary graft function will improve, but not back to the baseline that you were prior to this process. So we like to say it's your new baseline. So there is improvement, but we're not, right back to where we were prior to this diagnosis. And then the third is stabilization of your lung function, which is really there's no improvement in your pulmonary function, but it does not get worse. And then finally, there is the, which I feel I can't speak to the statistics on this, but for how long I've been there, I've never seen this where there is no response to therapy. And that is kind of dealt with on an individualized basis for, further modifications to this treatment plan.
Okay, so now I'm going to continue the chronic rejection part. It's called chronic lung allograft dysfunction. Normally we call it CLAD. It's the chronic rejection remains the limiting factors for the post-lung transplant patient survival rate. So up to 50% of the patients developed CLAD within the 5 years post-transplant. And also it's the most common cause of death the first year after transplant. So the criteria, how to diagnose the CLAD. The first and most important criteria is the lung function decline. So that's why we always keep telling our patients to come to the clinic as instructed, and do the lung function test every single visit. Because we need to monitor with this data, we can train the lung function. It's going up or down, it's stabilized. So if it's a FEV1 plus or minus FVC declined over 10%, that's a red flag to us. We would be very careful. And then it's possible CLAD. We will monitor for if the PFT declined over 20% in less than 3 weeks. We say, okay, probably possible it's CLAD. If it's over 3 weeks, but less than 3 months, is probably. And definitely is over 3 months. If this kind of situation lasts over 3 months, so we will say, oh, this patient, we will say it's CLAD, we will start our treatment. So the CLAD, there's 2 types of phenotypes. It's a BOS and RAS. BOS is called bronchiolitis obliterans syndrome. Basically, it's in our lungs, there's a smallest airway, it's called bronchioles. Once the bronchioles get inflamed, eventually scarred, it's obstructed. So then it's like it's becoming inflamed and scarred over time. So the scarring makes the airways very kind of hard to make the air flow in and out. So it's like this straw. The airways like the straw, get packed. So so that's why we call it obstructive. And the progressive for the BOS is normally very kind of slow over years. Patients can have the chronic rejection for years. So with the shortness of breath, fatigue, cough, and these kind of symptoms. For the RAS, this is a restrictive allograft syndrome. This is kind of rare compared with the BOS. Most of the BOS has lung function declined, but it's restrictive. This happened to the lungs, the parenchyma. It's called a fibrosis, like here. So here's the BOS is happening in the small airway, getting inflamed and scarred. So the lung is very hard to get the air in and out through this kind of the tubes. Like we say this airways as like tubes. But the RAS is happening in the parenchyma, in the lung tissue, the pink one here. So it's got a fibrosis and very thick. So it's like a balloon. It's very hard to expand. Yeah, doesn't matter how much air gets in, it's very hard to expand the lungs. So the RAS, this phenotype is more severe and deteriorates more quickly than the BOS. So the risk factors for the CLAD, for the chronic lung, chronic allograft lung dysfunction, is the first one is the primary graft dysfunction, which this can be happened right after the lung transplant, or acute cellular rejection episodes. We mentioned that earlier. If the patient keeps having this acute cellular rejection, that can eventually lead to the chronic rejection, or the GERD, the acid reflux, and also the micro aspiration. All these things can cause the chronic inflammations to the lungs. The infections, the virus, the CMV, flu, RSV, bacterial pneumonia, fungus. Fungal infection in your post-lung transplant patients, most common is as Aspergillus. So that's why we give our patients the preventive care, the treatment, the azoles, or the antifungal infections. And also the immune system response, as Ashley mentioned earlier, the AMR. Our body just recognized that this lungs is not ours, so they just started to get a rejection. And chronic inflammations, medication non-compliant. Like if you miss those of the the immune suppressant medications, the level will be very low, subtherapeutic. So that will put the patients on the high risk of rejection. In the long term, it will cause the chronic rejection. So how do we prevent or treat this chronic rejection? There's no like a robust high grade of evidence on the bar therapy. So in our program now, we use the azithromycin inhaler, steroid inhaler. Normally we use Advil and the statin. The 3 drugs together, we call it as a bar therapy regimen. And also we also will recommend patients to refer patients to GI doctor to check whether any GI issues, acid reflux or micro aspiration risk factors. Another treatment for this is photopheresis. Photopheresis has the most supporting evidence for now. It will demonstrate, it will help to stabilize the lung function and also will prolong the survival rate. But it's only for the BOS. It's for the chronic rejection that happens to the bronchioles, not for the lung tissues, the parenchyma fibrosis. That one, the RAS, does not apply to this, does not respond well to this photopheresis. If we decide to pursue this treatment, so our nurse coordinator will assist set up the treatment as outpatient, and also we will help to obtain the insurance approval. So for the RAS treatment, there's no established treatment for now. There's a cases report to use pirfenidone. This medication is used for the most of the time used for the pre-lung transplant patient who has the fibrosis lungs. So the photopheresis, no clear benefit for this type. And if we can consider the retransplant, but it's a high risk for this phenotype. And also this type, they deteriorate always is quicker and faster than the BOS. So the prognosis overall for this phenotype is kind of poor. So it's for either type, either BOS or RAS. Even when we consider redo, we'll be very careful because this is more challenging than the first transplant, because there's complications already for the first lung, and it's a scarring. And for the surgical standpoint, it will be more challenging. And also our body, the react would be or could be more can be stronger than the first transplant. And also the survival rate is lower than the first transplant. It's 50 to 60% patients at least 1 year survival rate, and within 5 years the survival rate would be it's 30 to 40% now. So the influence factors that for the post-lung second redo transplant prognosis, it depends on overall health condition for patients, type of the clade. As we said, BOS is better than the RAS, and the timing. So that's why we monitor our lung function closely to catch it earlier. What can we do as post-lung transplant recipients to prevent these rejections? As we mentioned earlier in the previous slides, we need to be very compliant with all the medications as ordered, follow up in the lung transplant clinic, as instructed. And if anything happens, contact your nurse coordinator right away. If anything happens to your GI, nauseous, vomiting, cannot take the medication, let us know. And if anything happens, the transportation issue, all the things cannot come to the clinic, let us know as well. And prevent infections, wear mask, avoid cross to decrease the risk of the infection, and resolve GI issue. If it's an acid reflux, we need to fix that. And always keep have the current vaccines and nutrition. Exercise as tolerated, keep strong. And if they like a pulmonary rehab program is also an option for patients to keep strong and maintain a good health. And yeah, so that's all the presentation for this time. And so next it's 5:15 now, and I think it's Dr. Nelson, and later if anyone have questions, we can go back to answer it.
Feifei, can I just jump in with the questions now, if that's okay with you?
Yeah, of course, yeah.
Okay. Ashley, I know you've seen the one question that Brent sent in. Do you mind addressing that to the group relating Hodgkin's lymphoma with treatment and treated with 3 times with Rituxans, left him with 0 B cells and 0 B cells, and B cells fight off infections, so therefore he gets IVIG and needs to have that for the rest of his life. He wants to know if with the IVIG, that when he saw this webinar, was talking about immunocompromised, that's why he wanted to listen to it. Is AMR anyway related to what he has?
Okay, so
Hi, Brent. I messaged you in the response, but to the best of my knowledge, AMR happens exclusively with patients that have received a transplant. It is the patient's immune system that is specifically attacking the transplanted organ, resulting in the rejection process. So I don't know if anyone else has anything else to add to help answer his question, but I believe that AMR is specifically related to post-transplant patients.
Yeah, I was going to chime in. I agree with that, Ashley. And I think the connection, right, is that you treat both with rituximab. And that's because both underlying issues are kind of a B cell issue. So in AMR, it's the B cells that are kind of overreacting to the transplanted organ. And so to treat that, we give rituximab to tone down the B cells. And Hodgkin's lymphoma is a very different pathophysiology to start with, but it also involves the B cells that are growing more than they should. And so that's why that's treated with rituximab. So I think different pathophysiologies that are treated in the same way. You do make a good point also that rituximab can and does really decrease B cell immunity, so increases infectious risks to especially viruses and bacteria, and monitoring for low immunoglobulins is a good idea, and lung transplant patients might be repleted with IVIG as well.
Thank you, Dr. Nelson. Feifei, we have a couple other questions. One is the body, John has asked, does the body ever accept the organ after 10 years or more?
Let me see here. I cannot see the questions.
I can read it to you. He's asking if the body ever accepts the organ after 10 years or more.
Oh, so that's a really good question. Yeah. With as time goes, we adjusted the immune suppressant the therapeutic level. We in the first year we started the level kind of high. Normally the tacrolimus is 10 to 15. Over 5 years we will decrease it to 4 to 6. Yeah, which means by then, yeah, your body probably familiar or just used to the foreign body, the donor's organ, but still you still need to take the immunosuppressive medication. You can never stop it. Yeah.
Okay, thank you.
Yeah.
Additionally, Claire has asked, how do statins prevent BOS?
Oh, that's a really good question. Yeah, that is they did the research. When they do the research, I know statins. We all know that statins is for the cholesterol level, right? We just decrease the LDL. However, when they do the research, they use the statins, steroid inhaler and azithromycin, the 3 drugs together. You cannot use individually. It's just three drugs together to stabilize the lung function. Yeah.
Okay. We have another question. Why is retransplant with RAS high risk?
Oh, as I said, because the RAS deteriorate really quickly. Yeah. As BOS can be patient can live with the chronic BOS for years. They can live with them for years. RAS, I think it's because it's the pathology for the RAS is in the parenchyma of the lungs, the lung tissue. It's like the pre-lung transplant patients, the lung kind of fibrosis. So just to go back to the pre-lung transplant. So that is more challenging.
Okay, thank you.
Yeah.
Scott has asked, does Medicare cover photopheresis?
I don't know for this. Probably Sandra know this because it's our nurse coordinator. Always help our patient to set up the photopheresis. Sandra, do you know that?
Hi, Feifei. Yeah, so let me turn my camera on. So the process of getting a patient established for photopheresis, most patients do it at Stanford. Obviously a little bit challenging for folks that live away, but to do it at Stanford, the APPs will place a therapy plan. Those are the orders for therapy. The patient will need to be assessed for whether the therapy can be done through their veins or if they're going to need a special implanted port. If they'll need the port, that's a procedure that's done through interventional radiology. And so we'll get you set up for that. And then we place the referral to the apheresis clinic at Stanford. And those folks have been great to work with. They'll work with you as well to get you going with getting you scheduled. It's kind of time intensive at first, every week for like the first few months or first month, I think. And then it goes to bi-weekly after the 3rd week, I think. So bit of a time commitment, especially up front, but that does taper off over time. So it's usually a process we can get going pretty quickly once patients decide they do want to proceed with it. Several steps for patients, again, going through the process of seeing if it can be done through your veins or if you're going to need a port, and then having that procedure done if you do need that, and then getting you set up at the apheresis clinic for your therapies. There are other places outside of Stanford to get it done, again, for folks that live away. UC Davis, for example, for people in the Sacramento area. So we're always happy to try to help with that to make it more accessible for patients.
Yeah, I think it's a case by case. Our patients, some patients Ray-Ban who said that I'm on photopheresis now outside the house outside is that Stanford Healthcare it with Medicare. So yeah, this patient is seems like the Medicare covered the photopheresis, and the other patient say I'm currently undergoing photopheresis for CLAD. Medicare does not cover it. So it seems it depends. It's really hard to say.
Okay. Thank
Yeah.
you. Okay, Steve has asked at around, he said around 30% lung function dealing with chronic rejections at 10 years out. At what level is a second transplant considered? Is it based in large part on PFTs, or are there other factors that come into play?
Yeah, so yeah, I can answer that question. It's first of all, it depends on the quality of life. Yeah, if the quality of life is okay now, and and overall the physical condition are okay. So and also the other factor is whether the patient is compliant with our instructions, whether they missed any follow-up or not. If the patient non-compliant, it's a really big barrier. We will not consider the retry redo. And also, this decision is really big. I think the selection committee meeting, and all our attendees, Dr. Dhillon will stay together to discuss. Yeah, it's really multi-factors. Yeah.
Thank you. Okay, we're gonna do one last question. What do you think about the Prosperous lung transplant rejection blood test assessment?
Oh, that's a really good question. Yeah, we use it now. Yeah, actually, in the acute care, in acute cell rejection, the diagnosis part, I was going to mention it. I think time is kind of limited. So yes, we use it for now. This is a the cell-free DNA. That's we can normally it's a tool to detect. It's a predictor for the solid organ transplant rejection. It can get from the blood, either blood or urine. But in our program, we always draw the blood. Yeah, it is a good indicator. We normally we choose the bronchoscopy, but if the patient lung function is kind of always good, and no concern that's the rejection. So we will, because bronchoscopy is more invasive. So we will say, okay, now we just feel confident, like, see, we can waive the bronchoscopy, use this, because this is just blood, that draws blood from your veins. It's kind of quick, convenient. Yeah. So if the blood test tell us there's a high risk, then we will proceed the bronchoscopy. Otherwise, we'll waive it.
Thank you. Okay, Bob,
Yeah.
I'm going to give it back to you.
All righty. Yeah, that was a great discussion. Okay, our final speaker today is Dr. Joanna Nelson, who we've already seen, Clinical Associate Professor of Medicine and Infectious Disease. Dr. Nelson will be speaking on a very pertinent topic, which is current and future treatments for COVID-19. So with that, welcome, Dr. Nelson, or welcome back.
Thanks, Bob. It's great to be here. Thanks for having me. I'm gonna share my screen here. 1 second. Okay, so I hope it's okay. I kind of broadened it a little bit to kind of encompass updates on respiratory viruses in general. So definitely we'll cover everything with COVID, but a couple other things that I thought people might want to know about. So I'll go over just an introduction to kind of like where we are right now with circulating viruses. Of course, that can change over time. And then highlight treatment and prevention of COVID specifically, but also just touching on influenza and RSV, kind of things that have changed in that realm in the past year or so. So this is data from the California Department of Public Health website. it's really comprehensive. You can really go at any time and kind of look up where we're at, both in California and via the CDC. The data is a teeny bit delayed, so we're looking at kind of end of November timeframe here, and you can just see for these kind of 3 major respiratory viruses, we're overall relatively low right now. Test positivity for COVID-19 is about 2.2% at the end of November, and flu and RSV were a little bit higher. COVID was kind of metastable from where it's been. It hasn't really changed. The flu numbers are still low, but flu and RSV are still low, but kind of starting to increase is kind of what this is overall saying. Kind of something new technology or that we're using more since the era of COVID is by looking at wastewater concentrations to kind of get a sense in the not just people who are being tested, how much virus there is, but just in the general community, how much virus there is. So that's another way we're tracking. This is looking specifically at COVID. So just to give more of a span over time of the percent positive specimens. Again, right now, relatively low compared to where we've been at other parts the prior 2 years. This is data from the CDC, just looking at what variant subtypes are out there right now. I think the last time I spoke to this group about this, we were kind of just on the beginning of the Omicron surge. So now we're kind of still in Omicron, but dealing with different subvariants. Not really important that you remember these things, but just to give you a sense, and it's pertinent to some of the therapies I'll talk about later. So also wanted to just touch on, what have we really seen in trends of COVID and like outcomes over time? This has definitely changed over time, and I think that it was reflected really nicely in this paper where they were looking at kind of characteristics and outcomes of lung transplant recipients with COVID in kind of different surges. So this 3rd surge cohort, which you see is the last column there, is kind of the Omicron surge technically, although honestly, it's not even that, this is data that ended in 2022. So what we've learned with COVID is that definitely things evolve over time and things can change. So this could still change. But just to kind of give a sense, one kind of nice thing about this data is that if you look at kind of disease severities, the severity of lung transplant recipients' illnesses over time has gone down, hospitalization has gone down, and mortality has gone down. Still kind of higher numbers than we would like to see in terms of those numbers. So, obviously still need to be cautious, but I think it just probably shows that, the level of immunity in our community and some of the treatments we have had a positive effect in outcomes of COVID and lung transplant recipients. So to go through the treatments, I kind of break it into mild disease where you don't need to be in the hospital, and then we'll talk next about when you need to be admitted to the hospital. So in general, any of these treatments, it's really great to administer them as early as possible. The treatments I'm talking about here are all antiviral, so they're really fighting like viral replication. So that's kind of why you want to give it early, is because most times the disease starts with the virus being in your body and it replicating. And so if you can slow that down, that can kind of shorten the duration of illness and decrease the severity of illness. So earlier is better. In the general population, we would kind of say, okay, if you don't get it early, then it's not even worth giving. That's not really true for solid organ transplant recipients, because we know in these patients that viral replication can go on longer just because of the immune system being low. So it has also been shown that later treatment can still be effective for immunocompromised patients. All of these therapies basically have been shown to reduce incidence of hospitalization and death. So that's what the aim really of treating is, to kind of prevent severe disease. So, and again, I'm speaking, for lung transplant patients specifically, and immunocompromised patients, this is kind of the treatments we think about. So the preferred antiviral is remdesivir. And if someone is outpatient and doing relatively mildly symptomatic, a 3-day course of remdesivir has been shown to be effective. This is IV, and we do have ways for people to come into Stanford to get this 3-day course IV over 3 days and not be admitted. Of course, that kind of depends on where you live also and how feasible that is. Paxlovid is a medication I'm sure you hear about a lot. It's a 5-day oral course. We tend to avoid this because there's pretty significant interactions with lots of other medications. But, perhaps other people in your family may be treated with something like that. Alternate therapy, there's another antiviral called molnupiravir. We consider this alternate because the outcomes weren't quite as good with this one compared to remdesivir, but this is an oral course which is administered ideally within 5 days of symptom onset. If one is hospitalized, we usually give remdesivir, again, which is an antiviral. And if you're sick enough to be in the hospital, we give it for usually 5 days. If you are sick enough where you need to be on oxygen, it's a new oxygen requirement, steroids have been shown to be very beneficial and improve mortality. So we'll usually do a 10-day course of dexamethasone. Sometimes we consider other stronger immunomodulators in cases of really severe disease. We tend not to use these in transplant recipients because they're very strong immunosuppressants. So there's definitely a risk associated with these. So this is definitely a very case-by-case decision, and I would say it's generally not done in the majority of transplant recipients, but occasionally for the rare case we might. And then, of course, supportive care. Other available therapies, sometimes we do also use convalescent plasma for treatment. And so this basically is plasma that's been donated by patients, and it's kind of pooled to have relatively high levels of COVID antibody in it. And so in essence, it's kind of giving your immune system a little boost, giving some passive immunity to help fight off the COVID. We don't have, this is not based on like a very high level of data. So it's not part of the kind of national treatment guidelines, but because in lung transplant, we are often in that space of not a lot of data, people have given a lot of thought to this, and we have definitely used high-dose convalescent plasma. It's considered with acute symptomatic COVID when there's concern that viral clearance is unlikely. So we talked about, that medication rituximab, that really decreases people's immunoglobulin, right? So they might not have a lot of their own immunoglobulin around. And so a patient like that might be someone who, as an example, might benefit from high-dose convalescent plasma for treatment. We also use it in protracted COVID infection. I talked about how sometimes transplant recipients can have really long viral replication where like they still have active virus in their system for weeks and weeks. And sometimes in that setting, giving some help to the immune system to fight it off can be helpful. Definitely should be considered when there's contraindication to antivirals. This doesn't happen all that much, but sometimes it might mean, someone's traveling from really far away and they can't really come for 3 days, but they can come for 1. So like this might be a good logistical treatment. And this is something we can also give as an outpatient at Stanford. And then, like I just said, can be given outpatient, but can also be given inpatient. So we've used it in kind of these scenarios. Emerging therapies. There is another trial that's being done and likely will be done at Stanford, but there's a lot of logistical things still being worked out. So I don't have details on it, but it's another kind of passive immunity called hyperimmune immunoglobulin, where basically it's just really high levels of COVID-specific immunoglobulin, which will be given to people for treatment as an outpatient. So that may be, and if and when this becomes available, you know, we'll definitely be communicating with the lung transplant team, so that may be an option to explore. In terms of prevention, vaccination is one way to protect yourself. So now it's recommended that the updated 2024-2025 COVID vaccine is recommended for every person 12 years of age or older. And this really is not, they call it updated, not a booster, because it's really updated against the current Omicron strains and still effective against the ones that are kind of circulating now and expected to be circulating. Because if you've had COVID, your body is like in the state of trying to make immunoglobulin against the COVID virus. We usually say if you've had COVID recently, then wait 3 months before getting the vaccine to kind of give your body a chance to have that good immune response. And then you can get the vaccine kind of to boost that. It's recommended that transplant patients should receive 2 doses of this vaccine 6 months apart. And also a note that, you know, if you have some life event occurring or something where it seems to make sense to give it sooner than doing it a minimum of 2 months apart. Other ways for COVID, other kind of, let's say, medical interventions for COVID prevention. There's another drug out called Pemgarda. This is a monoclonal antibody against COVID. So this works similar to kind of Evusheld did back in the day when Evusheld worked, where it's a long-acting monoclonal antibody. So it's given for prevention. And this is kind of based on, I guess, relatively small levels of data. It was approved through emergency use authorization for COVID prevention, so not kind of based on like a big trial. In general, it's recommended if one is going to get this medication that you should wait 2 weeks after receiving a vaccine to get this medication. Again, for those same reason, you want to let your body have a good immune response to the vaccine. It's given as a one-time dose and then can be redosed every 3 months. And in kind of the national guidelines, it's recommended, lung transplant recipients are a patient population which is considered highly immunosuppressed. So it's recommended to consider in this population. And with the caveat that, like, especially if one has contraindications to vaccine or they're on a B-cell depleting agent where they won't mount an immune response to a vaccine. So again, I've been talking about rituximab a lot, but when somebody's on rituximab, we basically think, okay, you can get this vaccine, but I really don't think you're going to have much response to it at all. So that might be a setting where being on something like Pemgarda could be protective for a patient. Of course, the caveats here, you know, is that it was kind of designed against the current circulating strains, and likely at some point it will not be as effective against strains in the future, but we haven't come to that point yet. Okay, so switching gears, and I guess of course I should mention in terms of prevention, which I'm not kind of highlighting here because I think everyone knows in terms of what Feifei said in terms of course, wearing masks and avoiding large crowds of people and trying to practice good hand hygiene and not being around people who are sick. That's obviously a very important lifestyle practice as well for prevention for all of these viruses. Okay, so switching gears to influenza. So again, this is kind of the detailed graph looking at our current numbers, which are relatively small, but increasing a bit in terms of percent positive testing for influenza. So it was about 7.5% at the end of November. So treatment for influenza, we do have a number of antivirals that work against influenza. The most common one we use is Tamiflu. And there's also these other ones, Zanamivir, Peramivir, Baloxavir, which we tend to think for in rare cases where you're concerned about resistance, but that's not all that common. And it's recommended ideally to start these within 2 days of illness onset, again, because, you know, in large populations of people when it was studied, really that was, you want to give it early for it to be effective, because immunocompromised patients can have more protracted viral replication. It's likely helpful to start I would start at any point in the illness when we find it in a lung transplant recipient. In terms of influenza prevention, of course, we all know that immunocompromised patients should not receive live vaccines. And there is a live influenza vaccine, so of course you don't want to receive that one. This is a change in the past year or so. It's now recommended that immunocompromised patients should receive either high-dose inactivated influenza vaccine or adjuvanted inactivated influenza vaccine. Basically, both of those two vaccines allow for a higher immune response. They're more immunogenic, so they're going to elicit a better response. And in transplant recipients, since you're on immunosuppression, that's important because we know that transplant recipients don't have quite as high an immune response to vaccines in general. So these vaccines can kind of overcome that a bit to hopefully elicit a stronger response and help with immunity. We all know annual vaccination is needed because the strains of the flu change over time. And usually this is during the late summer or fall. Also to consider for prevention that antiviral prophylaxis with Tamiflu can be used if you have a close contact with an infected person during the infectious period. And the things to think about here, close contact means kind of like you're within kind of droplet exposure, somebody's coughing, sneezing either on you or on everything in your house that you then went and touched. And the infectious period is usually like 1 day before one has a fever through 1 day after fever resolution. So if you know somebody for sure had the flu and you were, somebody in your household for sure had the flu, then kind of taking Tamiflu as prevention can be helpful. Just a note on the avian flu, because this is something we're hearing a lot about lately. So just kind of wanted to share with you what I am aware of. The H5N1 bird flu, based on what we know in humans so far, seems to be quite a virulent strain of flu. There have been 58 confirmed cases in the US, but these are all in people who have obtained the flu directly from either poultry or cows, because those are kind of animal populations where it's circulating right now. So it's all in people who are kind of working in dairy and poultry. And there's been no person-to-person spread. This is something we're watching really closely for, and our Stanford lab is actually actively surveilling all kind of respiratory virus flu cases that come in to make sure if this does happen, we are aware. Okay, switching gears to respiratory syncytial virus or RSV. So again, this is the in detail graph, relatively low numbers right now, right around 5%, but an uptick and might be a little bit higher now. So this is generally circulates in the community from November through March. So, the usual kind of respiratory virus that you think of. Like influenza and COVID, it can cause a spectrum of disease from mild upper respiratory infection to more severe pneumonia, bronchiolitis, and respiratory failure. Similar to all respiratory viruses can predispose to chronic rejection, like Feifei said. So that's one of the things, you know, in terms of treatment and prevention, with these viruses we're trying to prevent. We don't have strong evidence really for the best way to treat RSV. We don't have treatments that are quite as good as the other viruses, but there is a bit of evidence for this antiviral called ribavirin. So we will often use that. It's a pill and you'll take it for 7 days. Often we will also check immunoglobulins with any of these viruses to make sure your levels aren't low. That's something that can happen in lung transplant recipients, even in the absence of getting some of these other medications like rituximab. So it's something the team looks for, not uncommonly. And we might replete immunoglobulin with IVIG if those numbers are low. This is a new thing in the past couple of years in terms of RSV prevention. So there is an RSV vaccine now, which is called Abrezvo, which is an inactivated vaccine and was approved in 2023. It's been shown to reduce severe disease, hospitalization, and death. We don't really know how long it lasts for, honestly, because it just came out in 2023. So I think that's something that they're looking at now to see kind of how long this vaccine lasts. Right now we know it provides at least 2 years of protection. And because it was studied so far, or the first study really was in patients over 60 years of age, it's currently approved really only for people who are over 60. And so we really recommend anybody over that age get this vaccine. I've talked about it in to some younger patients because I think it probably is protective, and I'll talk about that in another minute, but it's a bit expensive and not all insurances will cover it. So that's something to be aware of. Sometimes people are very motivated and they've, you know, reached out to their insurance and figured out they could get it and have gotten it. There is a really recently published study, which is exciting, showing good efficacy in immunocompromised patients who are 18 years and older. So I think that the overall guidance will change in the future, saying basically that all immunocompromised patients should get this. But this study just came out, so the kind of guidelines haven't come around. And I think with that, it'll be easier to get it covered by insurance. Okay, so that's all I have, and I'm really happy to take any questions.
Thank you, Dr. Nilsson. We have several questions. The first one's from Ray. He's asking, how soon after he's completed chemotherapy for PTLD can he receive his COVID and flu vaccine?
Really good question. So it kind of depends on the chemotherapy. And with rituximab, which is one of the agents used to treat PTLD, the effects of it can last a while. So we usually will say, in general, for vaccines, get them about 6 months after that. With other chemotherapies, it's probably not quite as long. And we might vaccinate a bit earlier, maybe like 3 months or so after. The thing about COVID and flu is that they're very, maybe not so much COVID anymore, but you know, flu is very seasonal, right? So sometimes we will have people get the flu shot, even if we feel like so if you're on like a non-rituximab chemo and it's flu season, I would probably say just try to get the flu shot now, even though you might not have the greatest response, because by the time you're done with your chemo, it's probably, you know, you may be done with flu season too. So just to try to get any bit of protection, it makes sense to do it. And that's kind of similar, like people very early post-transplant, usually we don't give vaccines for like 3 months or so, thinking that their immune system's so low they might not respond. But we might give flu and COVID during that time period. Just knowing, like if you're in the middle of a pandemic or, you know, the season, it might make sense to give it just to try to get any protection.
From Michelle, she's asking if the Novavax is a good vaccine for transplant patients.
The Novavax.
I think that's the alternative to the COVID, the mRNA vaccines.
Mm-hmm. I think, yeah, it's a good question. I don't know that specifically because I haven't used those quite as much. I think it's safe, but I can dig into that a little bit more, Michelle, and get you an answer.
Okay, thank you.
Mhm.
Claire has asked if you could discuss whether or not getting a second dose of the flu vaccine for immunocompromised patients is a good good medical advice.
Mhm. I think in general, we are just giving the high dose flu vaccine, and that should be enough.
I know that's difficult to get though if you're not over 65. How can people get around that?
It should be easier now that it's recommended. And I think I don't know, maybe Sandra or Clara could. I think that's the one we give in our clinic, right?
That's correct.
Steve asked if I am on methotrexate for chronic rejection treatment, is the monoclonal antibody shot a better option than standard vaccine? He says that believe I had read that B cells are impacted by the medication.
Mm-hmm. I don't know. So I guess in general, like we don't really know the answer to that question. Nobody really compared vaccine to Pemgarda. I probably I wouldn't not get the vaccine if I were you because I think there's still I don't know, in terms of grading immunosuppression, I still feel like somebody who's on methotrexate should be able to mount some immune response, but it may be, you know, perhaps since you're on kind of augmented immunosuppression in general, considering Pemgarda would be reasonable. So I'd probably, you know, maybe do both.
Okay, thank you. Michael asks, where can I get, I'm going to say it wrong, Embriso. I think it's the RSV vaccine.
You can get it at pharmacies in general. I've had people get it at pharmacies. Probably some primary care doctor offices have it. We have it at our infectious disease clinic. So it's definitely around. If you know, if you feel like if you look around locally and you feel like you can't get it, I'm happy to, you know, help figure out how to get you to get it at our clinic when you're coming in to see lung transplant.
Okay, thank you. We've answered all the questions that have come in, and I would like to, on behalf of the Lung and Heart Lung Transplant PFAC, thank Dr. Dhillon, Feifei Yang, and Dr. Nelson for their participation today. We hope you found today's education symposium interesting and informative. We're looking forward to upcoming virtual education symposiums in 2025. Until then, I would like to wish everyone a very happy and healthy holidays, and thank you for joining us today.